Welcome to the 48th annual conference of the Viking surgeons, which for a second year is in a virtual form. It's been put together with great technical and administrative support from the education section and the Faculty of Remote and Rural and Humanitarian Healthcare at the Royal College of Surgeons of Edinburgh. The Viking Surgeons annual conference began in Stornoway on the Isle of Lewis off the west coast of Scotland in 1974 in the home of Martin and Jean Crossful. Initially, it was for rural surgeons working single-handedly in the Highlands and Islands of Scotland who faced similar clinical challenges. The main aims were updating on surgical practice, mutual support, and experiencing something of the culture in the community we have in our work situations. It was also an opportunity to invite super specialists from city centre hospitals to come to a rural unit to update the rural surgeons, and for those super specialists to experience the challenges of rural surgery. The delegates expanded to include surgeons from other remote areas around the North Atlantic Basin and attended for 3 days. Last year, we had 3 evening webinars because of the pandemic, which expanded the audience from 20 to 30 at the usual Viking meetings to over 500 from over 50 countries. Today, we have over 300 registered from 58 countries around the world, and we welcome you all, particularly those that are getting up in the middle of the night to join us for this. We have a full program, but before we get into that, here are the housekeeping messages. It's going to be divided into 4 sessions. Each session is a Zoom. After each session, the Zoom webinar will end, and you'll need to rejoin before the next session starts. So just use the same join link for each session. If you'd like to ask any questions, then the Zoom question and answer box, as you can see on the picture there, will be, these will be either answered live or will be typed by one of the panelists or one of the presenters. Please note that the chat is disabled. It's important for us to get feedback, and we've had good feedback over the last year of things that we want to improve, and we've tried to add in more discussion to this meeting so that you'll be able to hear the views of panelists and others rather than just being fed information in that. And there will be CPD certificates for attendance, but you need to complete the feedback survey and attend for the full duration of each session. There will be a recording of this, and you'll be able to watch that on the RCSEd website within 7 days. We have many traditions at the annual conference, including the enhelmeture of the local organizing or Viking chief surgeon, the chief scalpel. But let's get into our first session. My name is David Sedgwick. I'm chairing this session, and I've been a rural surgeon in the west coast of Scotland for 28 years. We have an excellent faculty with us. Firstly, I'd like to welcome our 2 panelists, Professor Mike Griffin, President of the Royal College of Surgeons of Edinburgh, after many years of being on the College Council. He's a distinguished esophagogastric surgeon from Newcastle in the north of England. Dr. Charlie Sidafin, a GP with 25 years experience working in rural settings. The major part of his career has been working in the Orkney Islands off the north coast of Scotland. He's clinical lead of the Scottish Rural Medicine Collaborative. They'll be commenting on the issues highlighted in the presentations and contributing to the subsequent discussion. I'd like to give a Viking welcome to our 3 presenters in this session. From Wagga Wagga in New South Wales, Australia, we have Associate Professor Kerrin Fielding, a consultant in trauma and orthopedics with extensive experience of running trauma courses over 30 years, along with being chair of the New South Wales Training Council. She's been a counsellor in the Royal Australasian College of Surgery for 6 years, and Kerrin is leading the college's rural health equity strategy, and we're looking forward to her presenting this strategy. Mr. Satish Yalamati has been a consultant colorectal and general surgeon in Kirkcaldy in Fife, Scotland for 16 years. He's a surgical training program director in the East of Scotland Deanery. Satish will be speaking on surgical training for rural surgeons. Our first speaker is Mr. Gordon McFarlane, consultant general surgeon in the Rural General Hospital in Lerwick in the Shetland Isles in the North Sea, halfway between Scotland and Norway. He has 17 years experience as a Viking surgeon and worked for 9 years in a rural hospital in Kenya before that. He chaired the Royal College of Surgeons of Edinburgh's Short Life Working Group, producing a report on standards informing delivery of care in rural surgery, published in 2016. He's the major organizer of this conference, and he's going to set the scene with an outline of the challenges in rural surgery, which will be relevant to many of you in other parts of the world. Over to you, Gordon.
Thank you, David. Share my screen. I think everyone should be seeing that now. So my job is just to briefly outline the problem that's posed in the title of the first session, the sustainability of rural surgical services in Scotland, how we've dealt with that to an extent in Scotland, and where we're going, where can we do better? And I think that's going to be relevant to very many of our delegates from across the world. It is, of course, an international problem getting surgical services to rural communities, and it was highlighted very clearly in the Lancet report on global surgery in 2015. We know from that report that 5 billion people do not have access to safe, affordable surgical and anaesthetic care. We know that there's only a very small proportions of all operations in the world are done in the poorest countries, where over a third of the world's population lives. And we know where the unmet need is greatest. For this meeting, we're concentrating mainly on Scotland, but we hope that there's messages that can be taken on board for different parts of the world, both in developing countries and in more developed countries. So rural general hospitals in the north of Scotland, there's 6 of them. They range between 60 and 110 beds. The average 3 surgical posts at each of these hospitals, and they are only 50% filled with permanent staff. We're very grateful and that we have more temporary staff, locum, long-term locum staff that are able to help out at these units and do so faithfully to keep them going. But the actual figures of each unit are down the right, down the sides there, and we're only about 50% capacity at the moment. The geography in world terms, in the likes of Australia, for instance, it's not such huge distances to get to our main referral hospitals, but 3 of our hospitals, we have to cross the sea, and the other 3 hospitals can also meet challenges of communication by road, particularly in the winter. So we do still have a problem that we need competent surgeons who are able to operate a huge variety of emergency and also elective care. And our transfer time can be 4 hours and can be a lot longer than that if the fog is down in Lerwick, for instance. Against that, we have trends within the profession that are becoming more and more specialized. When I became a registrar and trained as a registrar in Inverness in the late 80s, then the general surgeons there, 2 of them did the urology, so I was exposed to that. 1 of them did vascular surgery, so I was exposed to that. They all did some pediatric surgery, and it was relatively easy, therefore, to get a very broad training in general surgery. And of course, that is not the case now. The other thing that's come our way is the argument over volume outcome relationships, and there are papers almost every month in the major surgical journals that highlight this. And the case, there's no doubt that there is a volume outcome relationship for the more major procedures, pancreatic surgery, upper GI, and so on, but the case is still to be proven in some other areas, colorectal surgery, for instance. And then there's increasing subspecialization in the profession. We used to have a visiting orthopedic surgeon here, and when he retired, then we couldn't get another visiting orthopedic surgeon because they all specialized in their own areas. So they didn't want to see people with knee problems or foot problems when they were a shoulder specialist. So that's been a problem for us as well, and continues to be within the profession. And then there's this idea of fixed boundaries as well, which have their reasons. But if you're in a more major surgery center, then you don't necessarily want to take on, even insert chest drain if you're in a general surgical unit, when there's a thoracic unit just along the corridor. So there become more fixed boundaries in training, and that spills over into how we act as consultants. But a few weeks ago, we had a torsion in Shetland that we dealt with in a timely manner. That's a picture of it there on the right. But even some district hospitals in the UK are struggling to provide that sort of service for an adolescent. And where also do we find surgeons that are trained in upper and lower GI endoscopy, right up to and including the standard of screening colonoscopy. So training and recruitment and retention is a problem for rural hospitals. It starts off at a medical school level, where it can be more difficult for rural medical students' applications to be considered. They find it more difficult to travel down to interviews and so on. And there's a bias within UK universities to actually take students, fee-paying students, from overseas. Then moving through, the vast majority of trainees are trained centrally, and that's quite right. They need to be trained centrally because they need to be exposed to a good volume of cases, of each type of case. But it does tend to point their career in that direction. And training, of course, has become more focused earlier in careers. And we'll hear a little later on how that is being unpicked a little in UK over the last few years and moving forwards. And the certificate of completion of surgical training in UK requires a subspecialty interest. 20 years ago it didn't, and now it does, and that's potentially another problem for a generalist. And then there's perceptions overall of being a generalist, that it's kind of a second-rate career. But I would suggest to you, and I'm sure many of you are aware, that dealing with a extradural hematoma by craniotomy in the middle of the night in a rural area, or again, both these slides are from Shetland, dealing with a supracondylar fracture in a child and having to K-wire that. When you've got a vascular compromise that has to be dealt with at the same time, that I think is equally challenging to many of our specialist colleagues. The Scottish Government does actually support the concept of care which is nearer and closer to home and more personal, and did so in the care report as early as 2005. There was then various work streams that came out of that. The NHS had to provide and answer the questions raised in the care report and how they were going to provide services, and delivering for remote and rural healthcare was chaired by the then Chief Executive of NHS Highland, Roger Gibbons. And this was a couple of comments that were made in that report, that access to healthcare should be as local as possible for the whole population of Scotland, and there should be a 24/7 surgical service for emergency and elective care, requiring at least 3 general surgeons trained in remote and rural surgery. So I guess the discussion this morning is how far have we gone in providing the suggestions and the recommendations that have been made in these reports by the Scottish Government? Are there lessons we can learn from other parts of the world? What solutions can we look to? So I look forward to the rest of the discussion for this session. Thank you.
Thank you very much, Gordon. We'll not take any questions and comments at the moment, but we'll go and move on to if you do want to put questions, then put them in the question and answer box at the bottom. And we're now going to move over to Australia, to Professor Kerryn Fielding, and we want to hear how the Royal Australasian College of Surgery has been tackling this and their rural health equity strategy. Over to you, Kerryn.
Hello, and thank you for that warm welcome. I'd particularly like to thank David Sedgwick, who I met virtually at the RCSEd in Melbourne in May of this year, and Gordon McFarlane, who I met at the PSA in Bega, New South Wales in August of this year, for inviting me to speak to you today. I'd like to present to you the Rural Health Equity Strategy of the Royal Australian College of Surgeons, RACS, a patient-centred surgical care and sustainable surgical workforce in remote, rural and regional Australia and New Zealand model. RACS acknowledges its social responsibility to address health inequity through its levers of selecting, training, retaining and collaborating for rural surgical services and rural communities. We acknowledge the traditional custodians of country throughout Australia and recognise their continuing connection to land, waters and culture. I am today on Wiradjuri land. We also acknowledge the traditional custodians in New Zealand, Tēnā koutou, Tēnā koutou, Tēnā tāku katoa. This is Australia, and the orange state is New South Wales. On the right hand of the slide, you'll see New South Wales Local Area Health Services. I'm in the Murrumbidgee Area Health Service, the southern part of New South Wales, which is not actually all the way out to the far west, just central New South Wales. I'm an orthopaedic surgeon. I practice trauma, arthroplasty and spine surgery. In Wagga, which is the Riverina area, the central regional hospital of that whole area health service. And a photo here is of our Murrumbidgee River and the land near the Snowy Mountains as it comes down into the plains. So I've been in Wagga for 30 years. We have a rural clinical school in Wagga with medical students in 3rd and 4th year post-grad. I also work for New South Wales Health as the chair of the Surgical Training Council, which looks after pre-vocational trainees in the surgical space. I'm a RACS counsellor, chair of the Professional Standards Committee for the college, and I've been supervising advanced trainees in orthopaedics for 30 years. Health inequity. We know that our patients in rural areas have poorer access and therefore poorer outcomes. Our patients have shorter lives, higher disease and injury burden. There is disparity which increases with increasing geographical remoteness. This is particularly bad for our Aboriginal and Torres Strait Islander people in Australia and our Maori people in New Zealand. Those in remote areas have 3 times the avoidable death rate of urban people. 29% of Australians are rural and 25% of New Zealanders. The RACS 2018 census showed us that less than 12% of surgeons are living and working rurally. For 5 of the 9 surgical specialties, less than 5% of surgeons are based outside the cities. The Australian National Medical Workforce Strategy 2019 to 21 showed that 5% of Australian specialists work in remote and rural areas, much less than the data from RACS. Evidence-based strategies have been reviewed in the literature, and it were these papers in particular that were used to help set up the models for the RACS Rural Health Equity Strategy. So the 4 main areas that we've concentrated on in the strategy are select for rural, looking at rural origin, rural medical school placements, and rural work experience. And then train for rural. Train in rural with a rural curriculum at all points in the career pathway, from medical school through pre-vocational, vocational, and then post-fellowship training. Collaborate for rural. Let's improve the culture in medicine and talk about rural. We need our specialty societies, our associations, and other professional colleges, as well as allied health, transport and retrieval services, governments, universities, rural health memberships and advocacy organisations to be collaborating together and improving the culture. Let's retain for rural. Surgeons need education, post-fellowship. There are very important decisions regarding regulation, financial incentives, personal and professional support, safe hours, well-being, in particular for our specialist international medical graduates, surgical services, surgical teams, networks. We need to have bi-directional support and obligation from the urban centres to the rural. So with these 4 areas in mind, we put together bundled interventions spanning the whole career life cycle, tailored to the context of the area that the practitioner would be working in, that could be flexible in process and focused on outcome. This is Wagga Wagga. You can see on the map of New South Wales where Wagga Wagga is inside the little star on the right-hand side of the screen. And some of our towns, which are very small, up to around 2,000, 3,000 people, as you can see on the screen, like Cargellico, Hillston and Hay, they're over 3 hours away by road. The photos that you can see there are Wagga Wagga. Wagga Wagga is the biggest town in the Murrumbidgee Area Health Service. We're 65,000 people, but we have the major regional hospital here, which is a level 2 trauma centre, covering all specialties except for cardiothoracic and neurosurgery. This is pretty standard in Australia. We have 1 plastic surgeon, so that's reasonably limited, but we cover urology, ENT, orthopedics, general surgery, including those subspecialties in orthopedics and general surgery like breast cancer, colorectal, upper GI, etc. So the Rural Health Equity Strategic Plan. So the strategy addresses goals, as I've said, to increase the rural surgical workforce and reduce workforce maldistribution. Again, through those strategies of selection, training, and retention. And the idea is to build a sustainable surgical service in Australia and New Zealand through the Collaborate for Rural strategy. It aims to embed actions for rural health equity in all of RAC's activities and across all surgical specialties. The Rural Surgery Section Committee, which is chaired by Dr. Bridget Clancy, who's an ENT surgeon in Warrnambool, which is Western Victoria, was instrumental in developing the RAC's Rural Health Equity Strategic Plan. A few more photos just to break up my talk. These are photos around the Tumut area, which is coming down from the snowy mountains. You can see some snow there. Very beautiful farming land, lots of cattle, lots of sheep, and really a very beautiful part of Australia. So in October 2020, the RACS Council approved the implementation of the inaugural Rural Health Equity Strategic Action Plan as an area of focus across all RACS portfolios. The strategy is a flagship initiative for RACS in 2021. It demonstrates the commitment of our social responsibility and mission to address health inequity for our underserved communities living in rural, provincial, regional and remote locations of Australia and New Zealand. The Council approved the establishment of the Rural Health Equity Steering Committee, and this was to manage the principles outlined in the action plan and prioritise the actions for implementation. The Steering Committee will make recommendations direct to Council concerning the activities and deliverables of the strategy, and a senior project lead has been recruited to drive the implementation of the overarching strategy and to support the Steering Committee. So the Steering Committee, I was asked to chair as one of very few rural RACS councillors, and that is an absolute privilege. And my deputy chair is Dr. Bridget Clancy, who's been the chair of the rural section and a great driver behind the strategy. And we looked at people outside of RACS to support us through the steering committee. Professor Ruth Stewart, who's the National Rural Health Commissioner, is a procedural GP who works up in the Torres Strait in Thursday Island, and she's a great advocate for rural health. Professor Alan Samford, who's the president of RACMA, the Royal Australian College of Medical Administrators, is working in rural Queensland, and he also a great advocate for rural health. and Dr. Susie Lord, who's a rural counsellor for ANZCA, the Australian New Zealand College of Anaesthetists, is working with us. So we tried to get representation from outside the college. We also had representation from inside the college, from our education committees, from General Surgery Australia, from the Australian Orthopaedic Association. We felt that the general surgeons and the orthopods were the most important people to get involved early on, as these were the two areas where workforce distribution is really a problem. And then obviously from our advocacy committee from New Zealand, and very importantly from the Aboriginal Torres Strait Islander Health Committee at the college, and from our Maori committee in New Zealand. And then the most important of all in my mind is to have trainees. So we have three trainees from our RCSEd Association, our Royal Australian College of Surgeons trainee subcommittee, from very rural sites, one in WA, one in Northern Territory, and one in South Australia, to support us and to advise us through this process. So as you can see, the steering committee reports directly to the council, and this is really important to move the work forward quickly. But sitting under the steering committee, we have three other groups working with us. So we have an advisory group that has a representative from each specialty training board and society. And this was really important to engage all the stakeholders that will be involved in implementation. As I said, RCSEd, our trainee subcommittee, the Specialist International Medical Graduate Committee, and the PFEC committee, so it's Post-Fellowship Education Training Committee, that organises all the post-training fellowships. As I said before, our Indigenous representation is extremely important, and they are also represented in the advisory group. And then we had subject matter experts that we can call on when required. We also set up a curriculum working group. We've asked our research and academic surgery section to help us with the curriculum, as well as the rural section. And as well as them, we also got some people from our STP funded project. So STP project is Specialist Training Programs, a project that is funded by the federal government, which was initially set up to try and help the rural workforce issues, and funding had been given to hospitals in Australia to apply for trainees in special settings. And this has not actually been as good a project as the federal government had hoped, and that's because of a lot of the issues that I'll talk to you about next in relation to how do you set up a rural training program. And then our grid working group. So the grid working group is a combination of rural surgery, military surgery, and global health, with representatives from the AOA, the New Zealand OA, General Surgery Australia, New Zealand General Surgery Group, and subject matter experts. So the GRID working group is a special group designed for a dual fellowship, and that's a fellowship in surgery of whatever particular type of surgery the candidate would be doing, but including global, remote, rural, regional, and deployable curriculum for surgeons who want to, for example, be involved in the Defence Forces or in global work. And that's a picture of the road going out to the Hay Plain. So as I explained to you, Hay is at least 3 hours from Wagga, and we service that whole area. And that's the other end of our area health service, away from the Snowy Mountains, going out towards the back of New South Wales, which is mostly flat and featureless and nearly on the desert. So it's an amazing landscape. Okay, so just to have a look at some of the priorities, our first steering committee meeting was held on the 2nd of July this year, and the initiatives that we discussed were this major funding project from the federal government, the flexible approach to training and expanded settings funding. There's $27 million going into this particular area from the federal government to improve the healthcare of rural and remote people in Australia. And that's over a 5-year period. And the idea is that colleges collaborate, work together to put together applications for funding for flexible approaches to training in expanded settings. That is a very interesting project, and certainly we've been working very hard to get some projects up and running to be submitted to the federal government, but the timeline was very short. We had a meeting with them a couple of weeks ago, and the projects are supposed to be presented at the end of September. As is always the way with government, fix our problems and fix them fast. So the other major area that we were working on was hospital training post-accreditation criteria. So we've had a major accreditation review at RACS recently, and we've been involved with the accreditation group looking at accreditation special settings. And certainly we all know that it's impossible to provide the same standards in a rural site as it is in a major urban site. And so we've been talking to the accreditation team about the sorts of issues that we will need to make changes to for rural settings. We've put together an action plan of timeframes, and that's been sent out for feedback. And we were planning a New Zealand Rural Health Equity Workshop for September, which we actually delivered last week. The steering committee will also develop a work plan to coordinate initiatives across all of RAC's portfolios and specialty societies, associations and training boards. So just to have a quick look at the timeframes, the plan involved year one, setting up our governance structure, which we've done, setting up a monitoring and evaluation framework, and we have just appointed a consultant, an external consultant to help us do this, discussing the accreditation standards and being involved in that group, a review of selection initiatives, the FATES funding applications to the federal government, and having our New Zealand Rural Workshop. So we're getting through the first year timeframes extremely well. Year two, we need to have our measurement tools set up. We want to start a Rural Career Coordinator pilot. The RCANS forum, so we plan to have a forum in the Northern Territories. So RCANS is Rural and Remote Central and Northern Australia Surgical Service Strategy, and this is a strategy within the strategy to improve the healthcare and workforce in particularly the centre of Australia and the Northern Territories, where the problems are even greater than in other areas of Australia. So we're planning a forum in the Northern Territories for next year. We want our rural curriculum set up by next year. We're planning to set up an online rural hub so that anybody interested in the rural strategy, anybody starting a rural pilot site can have a centre where all the information, contacts is stored. We need to make sure that we have some models for remuneration set up between the jurisdictions, and that's part of the reason why we've had so much involvement with the medical administrators. We want that done by next year, and we want the Otaria New Zealand Rural Strategy starting next year. Then the 3 to 10 year plan is to have RACs, all bodies in RACs, all committees and groups in RACs to have rural representation, a launch of our grid program, networks for the RCANS area set up for general surgery and orthopedics, and we are hoping to start that in the 3rd year, and then the Australian National Framework. So progress to date. I've pretty much been through that, but as I have said, the governance structure is set up. We have had our input into the accreditation review. The selection recommendations have actually already been adopted by 2 of our programs, that's OH&S, ENT and vascular. We had the workshop with New Zealand on the last weekend. Our FATES funding projects proposals are well into development. We had a new fellow rural placement pilot, which we started last year with a small bucket of federal funding, and that is going to be reviewed. So that's 3 fellows in general surgery that post-fellowship fellowships have been placed into rural, and we'll certainly be reviewing the program. They're starting in February, so we'll be talking to them throughout the year next year to see how they're managing, and then we'll do a review of those fellowships at the end of next year. But as I said, that pilot has started. And then the collaboration is ongoing and has been quite extensive. And those are all the people that we've been collaborating with there. And I didn't mention RANSCOG, the College of Obstetrics and Gynecology, have agreed to partner with us in our FATES funding models for the Department of Health, and we've had some quite good collaboration with the Northern Territory Department of Health, and we're having another meeting with them in a few weeks to set up discussions about moving forward on a pilot program there. That's that RCANS program that I explained. And then Better Health Queensland is a small group of 3 local area health services in Queensland that has set up a project in ENT to service 3 major centres in Queensland with a networked model of training in ENT, and that's between Mackay, Townsville and Cairns, with the major site being in Townsville. It's a sort of hub and spoke type of model where the surgeons are supported from Townsville, and then there's outreach, and the registrars are going on outreach, and they've actually asked us to be involved with them in this project because they'd like to move this project out to other specialties apart from ENT. So we're very keen to be involved with them and perhaps run that as another pilot site into the future. So I think that the project's going very well. It's certainly being talked about at a very high level in many groups throughout the college, on most of the specialty training committees that I've heard. There's great discussion about the rural project, and we've certainly been trying to get out there and inform everybody of what we're doing. So far so good. Now, last slide, that's just a picture of our lovely lagoon in Wagga, where we have our regular Saturday farmers market, and the Civic Theatre, where my kids all did dancing and things on the stage when they were growing up. But I'd just like to say thank you very much for inviting me to speak to you today, and I'm really excited to come and visit your area in the future. I can tell you now we've been enjoying watching that program Shetland, which I think is very close to where you are. So just any questions, and thank you very much.
Thank you very much, Karen, for what is an amazing strategy that has been set up by the Royal Australasian Congress College of Surgery and also the New Zealand surgeons. And certainly there's a lot for us to think about there. I think what we'll do is there'll be 1 or 2 questions. I think you may notice one particularly from Beatrix Weber in the chat, in the question and answer, sorry. What strategies are for continuous medical training for established rural surgeons? Maybe you could type an answer to her for that. She's a surgeon in Shetland also. And we'll go straight on to Satish Yalamati, who's going to talk about training for rural surgeons here in Scotland. Thank you very much once again, Karen, for that, and we'll get back into the discussion later on. Over to you, Satish.
Thanks, David. I'll try and share my screen first and see if that's working. And put it onto slideshow. Right. Thanks, David. And I'm a surgeon in NHS 5 in Scotland. I'm conscious that the audience I'm speaking to is from across the world. And my training is essentially, my talk is essentially going to be on what's happening across in Scotland, but there are some wider principles to share across the globe. So I think I will probably try and reflect at places where it's relevant. So the topics which I'm going to try and cover today are essentially 3. One is to look at the standards of remote and rural training, which has been produced through a short life working group report in 2016. And the main aspect of my talk is going to focus on the early years of surgical training, which is happening across in Scotland. And I'll focus a little bit on improving surgical training pilot, which is ongoing in Scotland, which started in 2018. And through that, we are trying to change how we deliver training. So that's something which the principles of training can be transferred across in the globe as well. And having trainees across in remote and rural setting over the last several years, I will be in a position to try and give you some perspective of what's working well and what are the areas which we need to focus on. And finally, focus on future considerations. In terms of the first aspect, which is the short life working group, I think Gordon and David, who are on this panel, and has done a lot of work along with the help of the Royal College of Surgeons of Edinburgh, and they delivered this standards in terms of delivering care in rural surgery. The key recommendations, as Gordon earlier alluded to, is that the services to the patients should be provided locally where possible. And one of the key things which reading through this, which I found extremely important and relevant, is that the standards of care, irrespective of where it is provided, should be the same. So even the smaller hospitals should try and strive to provide the best possible care for the patients. Maintaining the surgical teams requires a flexible approach, especially in the remote and rural setting. And moving on to the training, I think they have come up with some sensible recommendations, which probably needs to be enacted. And that is to, within UK, we have, just for the sake of the general audience, we have the foundation. After they finish the medical school, they spend a couple of years of foundation training, and then they go into early years of surgical training in the format of core surgical training, followed by the specialist training is called ST, which is for a further period of 5 to 6 years. And what we have done so far is, for the early years of surgical training, we have got some trainees into the remote and rural hospitals. One of the key recommendations from this report is that the trainees, while spending the ST years, do spend a further time in a remote and rural setting for a period of at least 4 months. And there's also some consideration given to allocating 2 national training numbers within general surgery for trainees interested in remote and rural surgery. For the other key recommendations are that for those surgeons who want to work in a remote and rural setting, especially those who are coming out of the training system, they will still require a CCT, which is completion certificate of training in general surgery with a mainstream subspecialty interest. So the whole training, irrespective of where they are going to work across in the UK, there is this uniform process of getting the CCT and having a subspecialty interest. One of the areas where there's going to be a lot of focus on is the post-CCT fellowship, which Gordon and David might be able to add on later during the discussion, is that there's recognition that a fellowship is really vital here. Because when you come out of a surgical training program, especially general surgery, your core skills are on that particular specialty. Whereas working in a remote and rural setting, it means that you need to try and cross-cover other specialties. And this recognition that a certain amount of training and development of skills is required to cross-cover that. And the last thing there are quite a few recommendations. I picked up the ones which are relevant, and ATLS is quite an essential part for surgeons practicing in the remote and rural setting. So looking at the current surgical training position in remote and rural, as I had expressed earlier, that early years of surgical training has it's a remote, and so we are sending trainees across to these areas. Gordon earlier mentioned that there are 6 hospitals across of the same category, and we have 3 surgical trainees. And the exposure to surgical trainees to remote and rural has been going on for years, but there are 2 phases to it. One which has happened before the IST pilot came into place, and one since the pilot phase is in place. And the other aspect is the post-CCT fellowships. In terms of early years, I think the IST essentially is improving surgical training, and it's not improved surgical training. So there is a clear recognition that there has been issues with early years of surgical training in the past. And the 2013, the Shape of Training report has highlighted some of the key issues. It was a time when the number of trainees heading into general surgery was on a downward trend. The whole early years surgical training was so variable across the country. There was a lot more, there was quite a lot of imbalance between service provision and training, long hours and less supervision, or some units have performed extremely well, but there was lack of consistency, and there was an urgent need to look at at ways to try and reshape this training. So the Health Education in England mandated commissioned the Royal Colleges to explore this concept of improving surgical training. And this was funded by Health Education England. And the pilot phase started in 2018. Royal Colleges played an extremely important part in putting this together and delivery of it. Across in the UK, it was supposed to be all the 4 nations to be involved with it. Scotland had taken a slightly different approach, and we felt that it is a good opportunity to try and improve training across. There was a committed team within NES, and there were a lot of keen trainers and the training program directors who spent a lot of time together and felt that this is the opportunity, and let's take this en masse and try and improve what we deliver for early years. One of the problems over the years is for the early surgical training years are essentially 2 years, and then the trainees do apply for going into the higher surgical training through a selection process. And progression is one area which has been a concern across UK. The conversion rate from SCT to the first year of ST program was 45% across, that is a national average. And this is a data which is from the east of Scotland, and you can see that overall we've been a bit better above the national average. 2020 was an exception because the recruitment process into the ST3 training was different and was mainly based on portfolio rather than the interviews. But this year it's been different, so we'll come back to where we are normally. So nationally, one of the drivers for the new IST was the 45% average of people going into ST3, which was causing some deep thoughts amongst the people involved with the training. Scotland IST, as I said, took a slightly different approach. The main aspects of the pilot was that we explored the working pattern. 60% of the working was to be between the hours of 8 in the morning and 6 o'clock. So daytime working enables much more training opportunities. We've all been, some of us are probably established surgeons, some are probably going through the process of training. And one thing which is common, and one thing which I've experienced, is that the longer you stay in a placement, you develop the relationship with the unit, with the trainers, and you tend to get a lot more the longer you stay. So previously, all the placements were 6 months at a time, and trainees used to move. So we went away from that and said, and all the Scottish posts, both in the east and the west of Scotland, have got a theme. So it could be either plastic surgery, general surgery, urology, etc. But whichever the theme is going to be in, we gave them a 12 months continuous placement. So that enhances the training opportunities. So another aspect which we spent a lot of time, I think we have to recognize the work done by Professor Ken Walker, who's from Inverness. So he's the simulation lead on the IST program in Scotland. So along with him, the key members of the IST group sat together and put together a simulation package. And I will talk about that in a little bit more detail. But what we have, we put a package and thinking that if we have a structure to that, then we might be able to deliver a better training program. There's one slide which details the program, and I can go through that. The other area which we've found from feedback in the past is that there are a lot of keen trainers, but there's been a difficulty in how they work out between service commitments and taking the time to train trainees. So the traditional, if anyone is an educational supervisor across in the UK, they get 1 hour per trainee built up into the job plans, which is 0.25 as supporting professional activities. We felt that there's a lot more time required, and with the help of the Scottish government, we have been able to enhance that to 2 hours per trainee per week. And we also taken some opportunities to work with the trainers to get them through a particular, we had educational supervisor sessions and explained to them about what IST means and what is required to improve the training. And this is a work in progress, and we have clearly seen a lot of gains of, we're getting better, we're seeing better trainer and training interactions over the last couple of years. We've also spent some time, gone to all the health boards and spoke to their management and explained to them about what is required of the IST. Like what Karen did mention, I think we needed to ensure that all the units which are signed up to the program do deliver on what is required. And we went through a post-approval form to make sure that they do deliver. And also, if there are any areas where they felt that they could not, then we worked along with them to see whether it can be enhanced. So the main areas which we concentrated are the working pattern. We explored what kind of work are these trainees going to do, what is their on-call pattern. And also we focus largely on the quality indicators, which we still use to assess and see if the units are performing to what is supposed to. By and large, I think it's been a lot better than what we have seen in the past, but there's still some work in progress. The facilitated formal teaching, the more interactions between the consultants and the trainees having adequate exposure to the emergency workload, and also the ability to attend the multidisciplinary meetings and encourage them to do an audit every year. As I said, the 3 hospitals which host the IST trainees are in Fort William, Shetlands, and Western Isles. Fort William was in the program and then went off, and it's come August this year, we have got our trainees back into Fort William. In terms of the placements which we have across in Scotland, 95 posts across the board, with a slightly higher number in the west of Scotland. And this is just a representation of the east of Scotland posts. And what I want to try and just focus on is that though it's general surgical or it's an IST program, it covers all specialities except for neurosurgery in Scotland. But the bulk of the posts are within general surgery. When we look at training and looking at the core syllabus, which is available for trainees to work refer to, within the first 2 years of core surgery, there is a common content which is relevant to all surgical specialties, irrespective of what they want to do. And sending trainees to remote and rural encourages them to develop on this particular aspect. So that falls in nicely with the curriculum. This is a simulation package which I have outlined. So the 2 years of training, CT Core Training 1 and Core Training 2, when you look at it from another aspect, I think it's a 2-year program and it just runs through very quickly in no time. So what we have, this is a package which we put together. The monthly teaching days, which are across both the years, the local skills club, which have encouraged various hospitals to develop, especially with the pandemic situation where there were a lot of restrictions in traveling and training. So we have encouraged various hospitals to develop their own skills club, and there's a gradual increase in the number of units which have picked this up, and so that the trainees can go across there and spend some time developing their technical skills. The incentivized laparoscopic practice has been running for a few years, and every core trainee which joins the program, we give them a laparoscopic simulator to take away home. They have that for a period of 10 months in the first year before they return it. There is a set of exercises that need to do and upload some videos as well, so that we assess their technical development over this period of time. This year, for the first time, the incentivized program practice is expanded to vascular surgery, where a new model of the graft or vessel is being developed, and the trainees are going to be practicing on how to do vascular anastomosis. The other key areas, the courses which are up on the top row, is this surgical boot camp, exposure to the critical care course, and the rapid is a new course which is developed by the Edinburgh College, which is equivalent to the CRIS course, and we do support trainees to go for an arthroscopy or a laparoscopic course during the first year. Likewise, there are a certain set of courses which are within the package for the second year, which is the surgical crisis course. Basics course is the cadaveric course, mainly for general surgical and urological trainees. This is supported by the Glasgow College, and they've been doing this for quite some time. And another new course which is coming into the equation this year is the consultation skills that matter for surgeons. So largely, we have had a lot of support from both the colleges within Scotland to deliver on the simulation package. This is the laparoscopic simulator box which we give to them. And the picture on the right is the activity going on at the boot camp. There's quite a lot of supervisors and the trainers who engage with the process. So they get very close one-to-one teaching and training. The pandemic obviously has brought in a lot of new changes. I mean, the delivery of training and teaching has been disrupted, but anyway, it has opened up other avenues, as like what's happening today is we are meeting through alternate means. So that's, in a way, it's opened up probably in a way better ways of providing teaching. There's a lot more emphasis on simulated learning, which is on the rise, and also the skills clubs, which I've spoken to earlier. Moving on to the next aspect, which is the surgical training in a remote and rural setting. And if you try and look at what trainees gain within with the rural placements, I think by and large, being a program director for quite a few years, I've seen trainees go in and out of those units. There's sometimes quite a few of them have anxiety about trying to go across to a remote and rural setting, not knowing what to expect. It's really pleasing to know that they really, and there's been a consistent message which comes across from them, that it is a different experience, largely positive. And apart from provision in developing their skills within general surgery, what they find the most important aspect is the exposure to other specialties. Briefly, I think going back, I think when during earlier days as surgeons developed, they were doing a lot of things apart from general surgery and urology and orthopedics, and some part of gynae. So they were more of a generalist, and we've gone from that to specialization in various other specialties, and then more on to the subspecialization, which is happening now. The trainees, because they've had experience working in other units and as foundation 2 trainees, one thing they found completely different is the ability to work cross-cover, see different specialty patients, which is being seen as a largely positive experience. The units where we send our trainees now have got plenty of experience to develop their basic surgical skills and also the endoscopic skills. One thing trainees really like is to go to the appropriate list. No point getting them to complex Whipple's procedure and things like that. They don't gain much, but they want to be at a stage where they're at an early stage of training. They want to do the basic skills and focus on that. And the remote and rural setting seems to be an ideal place for them to pick that up. And one thing, other aspect which came up across is because there are not many trainees across, they somehow develop a very close professional relationship with the trainees, which has translated into clear benefits. Pandemic. So during the last year, what are the concerns which came across from trainees and also from the program is that there's a perception that the amount of operative experience has largely reduced. And we analyzed the logbook over the last year from August 2020 to June 21. And this is the analysis from the remote and rural surgical trainees. It consists of, we didn't have Fort William at that point, so it's mainly data from Shetlands and Western Isles, the first block of 6 months and the subsequent block of 4 months. The crucial thing to look at is two. One is the total operations which they've been exposed to. What we were trying to aim for is about 100 procedures per 6 months for the trainees. And you can see that both Shetlands and Western Isles have delivered extremely well on that. And this most important thing is the training opportunities. Yes, it's good for trainees to go into theaters, but are they getting to do something? And what we're sort of working towards is a 50% of the operations. If the trainee has an opportunity to get trained, that's probably a good thing. And you can see that the training opportunities are extremely high, especially for the first 6 months. And I think if we count the data for the subsequent 2 months block or the second block, things would have been much higher. Trainee feedback, I'm conscious of the fact that there is a trainee session later this afternoon, so I don't want to dwell too much into this, but largely we, as a program, and also through the GMC training survey, as well as the Scottish trainee survey, we do get feedback from the trainees, largely positive. And the key areas is the close working with within the members within the unit, less competition with the trainees, and also the ability to work cross-cover other specialties seem to be the highlights of the feedback. Clearly, there are risks and downsides with any remote and rural placements. As Gordon mentioned before, that there is a 50% gap with substantive posts. And clearly, when you send trainees, when we send trainees across, and if there's no trainers to provide the training and the supervision, it puts the trainees in a very difficult position. So that is a risk which is there. And we've been trying to mitigate those issues, but it is something which has need to be looked at it in a wider way. And the other aspect is that if they've been, luckily it's not been happening in the last couple of years, but before that, if there were trainees which got pulled, if they pulled out of the program at the last minute, it creates a gap. And because these rotas are essentially based on a smaller number of people, it has a negative impact on the remaining trainees. The other thing which is becoming an area of a bit of a concern for us, and we're trying to work with the deanery, is the aspect of travel expenses. So traveling across for the regional training is an expensive affair. The flight costs are dear, and we need to see how we can support the trainees to attend to these important training sessions. Moving into the future, the basic question to ask is, should remote and rural surgical training be different? And my honest answer is yes. And I think it goes back to the fundamental aspect of, we need to ask a question, what are we training people for? Yeah, so the training, the delivery of care within remote and rural is different compared to other district general hospitals and teaching hospitals. And this is well known, but are we doing enough to try and circumvent the problems and try and get the right training to the people coming out of the program? So that's something which we need to really focus on. And I think part of the discussion later on might go on to that. Moving into the future, I think the key aspects is that we currently have surgical trainees going into remote and rural settings, so they do have exposure at an early stage. And following on that, when they go into the ST years, the skill acquisition usually happens in non-rural centers within the teaching hospitals and the DGHs, rightly so because of the volume of work. And then they do get this CCT and this concept of fellowship coming in before they become rural surgeons. One area to consider, as outlined in the report, is whether we provide more rural placements during the ST years, which is lacking at the moment. Obviously, things moving forward, getting more placements into the remote and rural setting will be ideal, because that translates to the fact that more trainees go across there, they see what's happening, and there will be a few trainees who would very much like that experience and would like to go back to those kind of hospitals to spend the rest of their life. So currently, I think we're not giving enough opportunity for trainees to go and experience that. And as a training program director, I think the timing of sending a trainee across to the remote and rural setting is something which I'm not entirely certain whether we've got it right. Currently, we're sending the trainees at the start of the program. And the question is whether we send them a little bit later once they gain some skills across in the busier units, like spending some time in general surgery, trauma and orthopedics and urology before they go there, so that they can probably try and practice their skills in a much more constructive way there. The other aspect is the study leaves, which I've alluded to. Lastly, promotion of remote and rural. I think Gordon and David have been doing this for years. I do remember that in Glasgow, quite a few years back, we had the deanery had put up stalls to encourage students to come up, and that's the first time I met both of them, and they had a very impressive stall laid out, and a lot of people were going into those areas. So the promotion is a key part, and that needs to continue, which will probably lead to building up sustainable teams in the future. So just finally to conclude, as far as the surgical training in Scotland is concerned, I think early years we have got an established program, but clearly there is an ongoing process of trying to improve the delivery of training, and the IST, in my view, is doing what it's supposed to. It's probably, I mean, it's not a biased view, but if you're even looking at an unbiased view and hearing from the feedback from various quarters, what we're hearing is extremely positive, but there's still a bit of work to do, and that will continue. I think a closer interaction between the remote and rural hospitals and the program in the future will probably help us to outline a better program for those trainees going there. Pandemic has brought in some positive changes in delivery of education and training, and that will continue. But finally, the last thing I want to conclude with this is that I think there's still a bit of work to be done for the middle and later years before people pick up their career in remote and rural surgery. Thank you.
Thank you very much, Satish. We've had a lot of information given to us. There's been a very structured approach in Australia. We've heard from Karen Fielding. Gordon outlined the problems which are common to most of the people, surgeons working in remote and rural areas, and the challenges that we have. And we've seen some answers from Scotland. I'd like to go to our two panelists first, just to get some comments from them and thoughts about what they see as the difficulties and challenges, but what they see as positive from what we've heard today. I'd like to go to the president of the college, Professor Mike Griffin first, and then to Charlie Sidifin.
Great, thank you, David, and great talks, all three. And first of all, pay tribute to yourself and Gordon for being wonderful role models in providing the service that you do. And it's on another level. You've got to understand that you can't be what you can't see, and you two provide that in spades. And in coming back to what Satish was saying about encouraging trainees to perhaps think about a career in remote and rural surgery, if you don't have people like you, they won't do it. They can't do it. And so that's important. So I enjoyed Gordon's talk, particularly about the challenges. Karen gave a great presentation, and I have been aware of the remote and rural section of RACS for many years. I've been the visitor there on a number of occasions well, 6 or 7 occasions over the years. And the remote and rural section is extremely vociferous. It's very active, and they're very well organized. And what a great presentation that was, and how well the Australasians are in putting things together. And I think that is a stimulus to everybody. In coming to Satish's presentation about training, I do need to correct one thing about IST, particularly in England. It was not administered by all the colleges. It was administered by the Royal College of Surgeons of England. They were paid huge amounts of money by HEE to do that, and it's been an unmitigated failure. Whereas actually NES has rolled IST out in Scotland, and it has been a real success, as you heard from Satish. And I think that we're all buoyed up by that, and it is absolutely crucial that those training opportunities, particularly in Stornoway and in Fort William and Orkney, are there for our trainees. Again, the issue of if you don't see it, you can't do it. And you can see from the number of procedures that have been performed personally that they are getting good opportunities there. And just like in England, the new medical schools that have been set up for defined reasons. For instance, the medical school in Sunderland has been set up because they know that the vast majority of people that train in a region stay in the region once they've qualified. And this was designed to bring GPs into the area. And so if we do not bring people in for training into these areas, they will not have that stimulus. And if we bring people there, they may well want to spend their lives there. So absolutely essential that that's the case. And I think that the attraction of remote and rural is there now. And we've learned so much from this COVID pandemic about telemedicine, things and Zoom calls as we're doing right now. But the ability to share imaging and asking for help and advice and so on is so much more effective and detailed with the digital age, that this supports the work that Gordon and you, David, are doing, and gives you that backup that has been perhaps in some respects lacking in previous generations. And so I think that there are a lot of positives now. And I would probably finish in my comments by saying that NHS Education Scotland have been charged with developing the new credential in remote and rural healthcare. And I think that this, it was discussed yesterday, can I tell you, at the General Medical Council. And I have no doubt that it is going to come through and it will be administered by NES. And I think this will be another boost for remote and rural in the UK and in Scotland in particular. So I thought great presentations, very thought-provoking, but I think that we need to be very positive about the future. We've got to think about recruitment and all the things that we've just mentioned, and we've got to think about retention. The one thing that the Australasians do well, I think the Australasians always look at finance, and Karen may want to comment, but I know that there are incentives, financial incentives for those working in rural areas in Australasia, and perhaps that is another potential way of supporting our remote and rural practitioners, because it is an unusual and a challenging environment. So I could go on forever. I think this is a fascinating area, but the college, with its faculty of remote and rural and humanitarian medicine, we are absolutely wedded to this, and please join us. The other final comment is that we have put together, and Gordon will know this, a sort of a collaborative where we are providing support for very well regarded recently retired surgeons to provide that locum service to support those working in those 6 hospitals. And Simon Patterson Brown has been very active in supporting that. And I have pushed this with Ian Finlay, it's the Scottish government, and it has that support. So I think there's a lot of things happening that are good. I'll shut up.
Thank you very much, and thanks for coming and commenting on that. Karen, I'll come to you in a minute about the comments that were made by the President about Sunderland and living and working in the area, and also the financial side. But I'd like to go over to Charlie Sidafin, who's joined us from Orkney, who's a GP who's been involved in recruitment and also working and using the services of a rural general hospital and the surgical services and medical services. Charlie, over to you. Any comments?
Thank you, David. Really interesting presentations, and thank you very much. I think really importantly, one of the things that we've identified in general practice is the importance of being able to identify the issues that are stopping people from coming out to rural, and then building structures around that. And what we've heard this morning have been some excellent presentations around about the structures that you're putting in place to address those issues. Maybe just very briefly, I'd like to add 2 other things that I think have been really important in the general practice experience. The first one is around about teamwork and networking. So here in Orkney, we've got 10 outer islands, all with which previously 10 years ago had all single-handed GPs on them. We were completely unable to recruit them. And we created what we call the Isles Network of Care, which brought the practitioners together a weekly basis through video conferencing. And that, as a single 1 hour intervention, has completely and utterly transformed. We've done lots of other things, but I'm not going to bore you with all of that. And we've changed the model so it's not all GPs, it's a mixture. And those weekly meetings are about case discussion, about learning, and about providing mutual support. And we've also seen over the last few months the beginning of the Rural General Hospital Grand Round once a month. And again, a really good example of how you bring like-minded people together so that you share ideas, you share thinking, but you build energy, you build support, and you create a sense of direction and identity. And the second bit I think that might be useful for you to think about and is around about flexible working practices. So what we've done initially in Orkney, and this developed over a 10-year period, and we've just in the last 2 years done a very successful recruitment campaign called Rediscover the Joy of General Practice. And one of the key elements around that, there are a number of key elements, but one I want to talk about is around about the flexibility of contract. And so what we've realized, and Michael has just alluded to that about the recently retired surgeons, but as we go through our lives, our careers, our needs and our availability to work, it changes. You know, when we get into our 50s, we lose one of those things that's tied us a lot, which is often our family. And we're able to be maybe more flexible in the way in which we work. So what we've developed is an oil rig model, if you like, of working. I work on one of our outer islands. I'm there for 3 weeks out of 9, working 24/7 when I'm there. And I have 2 other colleagues that do the same. And what that does is allows us to have other interests and other work and to support each other. But one of the really key issues here is that when we're in that position out in Westfield within our practice, we take full responsibility for all aspects of the practice. So that is clinical care, it's about administration, and it's also about what you might call the political side of it. So being able to attend the committees and everything else. Now, when we looked at that and tried to put it into the Balfour Hospital, that model, what happened, that overall responsibility for administration and the political side of it fell just on the one substantive consultant physician in this case. And the others that came and rotated in, if you like, behaved like registrars. They didn't take that responsibility. And I think it's really important to understand that need to take responsibility for the entire service. So that would be my comments. Thank you.
Thank you very much, Charlie. That's certainly some helpful things there for people to think through on that. And certainly the work you've done in Orkney has been absolutely amazing in recruiting and retaining people there, and also to look at the continuity issue, which is an important one there, in that to make sure people take the appropriate responsibility. Karen, I'd like to come back to you again now. And there was a comment there about living and or training in an area and then potentially staying there, and talking a bit about remuneration or how you can encourage people or retain them.
That's very interesting point, David. Thank you. So in New South Wales in particular, the government introduced remuneration packages for specialists in rural areas. It was about 20 years ago, actually, and we were given, so in the city you get paid a sessional rate for doing your public work, which is a couple of $100 an hour. There's a special rate that's set up and it goes up with seniority, and rural surgeons were given what we call fee for service. So that's a kind of Medicare national health rate for your surgery, and that includes post-op care, and it's significantly higher than what you would get as a sessional rate, and that's all very nice, but the problem is it didn't work. So people didn't really want to go rural just for the money. The reality is that we have a higher rate of people that are not privately insured in rural. So even though you make a bit more money in the public sector, the rotas are worse, you're on call a lot more, and there's significantly less private work. And in a lot of centres, there are no private hospitals in the smaller towns. So it actually didn't work. That is part of the strategy that we need to look at remuneration. In areas like Wagga, where, for example, we have got 9 orthopedic surgeons here and the population is 65,000, but we do service 250,000 people for most orthopedics and then 500,000 for spine. And I'm the only spine surgeon, so that's completely ridiculous. but so it works in an area where you've got a core group of people, and then you can attract more people because the remuneration package is reasonable. And then the other thing the government did was give an extra $10,000 a year to specialists working in rural and remote areas for education purposes. So you could access that money if you're going to a conference, or if you need to backfill your position, something like that. So the problem is that you still got to get them there. And we know that rural people tend to like living in rural. And so part of the strategy is giving points to people that have trained rurally, that have been brought up rurally for selection to get into training. You know, in Australia now, you almost have a PhD to get into orthopedic training. It's so competitive, which is completely ridiculous if you ask most people. And so now what we're doing is looking at selection and saying, okay, well, you've given 4 years of rural service, or you went to a rural medical school, so you're going to get some points in training, which will be equivalent to, for example, a PhD. The other thing that's difficult in rural is research, and research has been, you know, really highly regarded in applications to training. And so we've got some models set up. So the clinical trials, which actually came out of the UK, you guys do that really well. So we're going to start boosting those clinical trials in rural and supporting rural areas to get involved in those clinical trials so that trainees can get involved in research. So yeah, the remuneration thing just doesn't work alone. You've got to still have people there. And just picking up on what she said before, you know, the rural training is probably the most important part of it. And we get lots of people in the first few years, just like you, who want to do rural training. They come to our rural medical school. They're here for a couple of years as an intern and as a resident. They might do an SRMO year in general surgery or in orthopedics, but then they get dragged back into the city to do all their training, and then they never come back because they get married and they get set up in the city. So we've got to do a significant proportion of that training in rural, and that is the plan of the rural strategy, to do about 70% of the training in rural, keep them in rural, and they just go back into the city to do their super specialty terms, like they might do their neurosurgical term or their cardiac term and things like that. But we know that rural surgery, the caseload is high and it's broad, and we've looked at the caseloads, and there's no reason they can't do a majority of their training in a rural site.
Great.
I don't know if that helps you.
It does, yes, absolutely. And I think it answers Beatrix Weber's question about strategies, that you have a pot of money that actually enables people to continue their training when they're rural surgeons, and the difficulties of getting off the island or away from the area to have backup and support as well. Going to go
but again, as the others said, you know, the pandemic's completely changed that, hasn't it? I mean, our access to education now is completely different. So, yeah.
Yep, we've got a couple of minutes. This session could go on for hours, I know. Gordon, I'd like to come back to you. You presented the challenges and the problems that we're facing. Have you heard some solutions?
Yes, I think it's been encouraging to hear what Australia are doing. Some of their ideas, both at a council level in the college, and also what they're doing practically to help trainees through. I think that's been really helpful, and to hear from the other end, from the training end, from Satish, how he sees the rural training as well. And on that note, there's been several questions as well in the Q&A about training, and yes, it is still possible to have a good training in UK in rural surgery. Good to get exposure to the rural to the 6-month program early on, and then good to continue with as broad a base training as you can. You're going to have to specialize. It's going to have to be colorectal surgery, probably the best one to do. But and then there's a fellowship afterwards to add in things like urology and orthopedics. But there's a talk about the fellowship that's been put in at late notice this afternoon, first session this afternoon by Professor Ken Walker. So that'll be there. So stay tuned for that. You're on mute, David.
Thanks. It's 10:45, only once in this session. That's amazing, actually, for me not to be muted. I know people would love to be muting me many times. But I want to say thank you very much to each of the presenters, to the panelists who have given some comment on it. Thank you also to the questions. We'll continue answering questions that are in the question and answer box during the course of the conference. We're going to take time now for a cup of coffee or a cup of tea or whatever it is. But it just remains for me to say thank you very much indeed to the college for supporting this and giving the technical support, and to each of the presenters who've put their efforts into presenting today, and for the panelists and their comments. And I hope you'll join us again, log in again at 11 o'clock, and we've got a session, a clinical session with some on that, and the trainees are also going to be there, and we're going to welcome Stuart Ferguson will be chairing that session. So go and have a break now, and we'll see you back in 15 minutes. Thank you.